Hello everyone, and welcome to a new session of clinical pharmacology. Today we are going to speak about local anesthetic as a part of central nervous system clinical pharmacology. I am Dr. Khalid Hassan, Associate Professor of Clinical Pharmacology, Drug Therapy and Clinical Research. As you can see here from this slide, you can see the overview for local anesthetic. The purpose of local anesthetic to produce loss of sensation in the specific area of the body. It could be the eye, could be the ears, could be the teeth, could be the skin. If you have wound and you need to do some minor surgery on the skin, or like teeth, or like teeth extractions, for example, or tooth extraction. So we need to lose the sense of pain in order to implement this maybe minor surgery. How this medication work, how local anesthetic work, as it's known that local anesthetic inhibit sensory transmission from the target region, from the skin, from the eye, from the ears to the central nervous system. In this case, our brain will not maybe react by sending some maybe suffering from pain or sending some reflex responses. How this medication work? They divide this group of medication, local anesthetic, in two main group of medication. We have esters, local anesthetic. We have amide, local anesthetic. How this medication work again? This medication inhibit or block sodium channel on excitable membrane. So that we have membrane responsible for pain sensation, and our medication local anesthetic inhibit or block the sodium channel in that maybe membrane or that organ. Okay, so for category here, we have classification for the local anesthetic. As you can see here, local anesthetic classification classified to amide or ester. For the we have it amide or ester. For amide, we have short acting, medium acting, long acting. For short acting, we have articaine, medium acting lidocaine, the most popular medication in clinical use, followed by articaine. Then we have long acting bupivacaine, ropivacaine, and epidurals. So the most popular one in the practice here, bupivacaine, ropivacaine, long acting. So here we need to remember which one medium, lidocaine, which one long, bupivacaine, ropivacaine, and this one belongs to the amide. Related to the ester local anesthetic, we have short acting, we have procaine, and we have benzocaine, and we have medium acting, we have cocaine, and then we have long acting tetracaine. As you can see here from the slide, we have differential sensitivity of nerve fibers towards the local anesthetic. When we apply local anesthetic, the first pain will disappear. The first sensation will be the sensation of pain. The question now, which nerve fiber responsible for transmitted of pain? So you can see here we have the specific type of fiber responsible for pain signal will be a delta fiber and C fiber. So you can see here we have a delta fiber and C fiber. This is the most maybe nerve ending nerve cells responsible for the transmitted pain. So most pain signal in the human are transmitted by two type of nerves, A delta fiber and C fiber. Number one. Number two, they said that this pain signal normally transfer maybe in small nerves rather than in large nerves, mostly available in myelinated nerves more than unmyelinated nerve. What that mean for us? Does that mean anything? When you use local anesthetic, when you inject local anesthetic, when you apply local anesthetic, what happens there? So the local anesthetic will select mostly the A delta and C fiber delta. So what we have here, we have neurons, we have several type of neurons. So the A delta fiber and C fiber will be selected by local anesthetic. The most sensitive nerves will be the small nerves. The most sensitive nerve to the local anesthetic will be myelinated nerves. Very important question we need to be addressed here. What type of sensation will be disappear first when you inject local anesthetic in the skin, on the eye, on the ears, or any part of our body, the first sensation will be disappear, will be pain. So the first sensation will be appear pain, sensation of pain will disappear. The sense of temperature, the second on the list, followed by touch, sense of touch, then deep pressure, and the last one will be motor function. So when you inject local anesthetic, you can see the patient maybe lost their sense of pain, then sense of temperature, followed by sense of touch, followed by deep pressure, and the last one will be motor function. We don't like to go all deep, down to all these function to be dysfunction. What we need only and for the surgery, for the minor surgery, sensation of pain mainly and temperature second, but sensation of pain, this is the main purpose of local anesthetic. Okay, local anesthetic make the patient lose sensation of local pain. This is an important thing. This is maybe the core concept of local anesthetic. This is the most important slide on local anesthetics uh, because we need to understand how the local anesthetic work. If you look on the skin surface or on the any organs such as eye, nose, ears, whatever, so you can see here we have on the surface we have tissues, we have organs, and we have cells. On the cell surface of these cells we have channels, and these channels called sodium channels. And these sodium channels allow sodium. This sodium channel allows sodium to enter the cells. When the sodium enters the cells, the sodium carry the positive ions, cause a depolarization. When you talk about depolarization here, when you talk about depolarization, the result will end to the stimulate and transfer impulse to the central nervous system. So we have here the transfer of sensation from the peripheral tissue to the central nervous system through maybe allowing sodium to cross the channels, sodium channel to cross from outside the cell to inside the cells and cause depolarization, stimulate these tissues and bring this stimuli to the central nervous system. Now you can see here we have the sodium channels and we have the receptor, and someone can tell me here the local anesthetic receptor, here we can look on the local anesthetic receptor here. Local anesthetic receptor located on the inner side of the sodium channel. So you can see it here again, local anesthetic receptor located on the internal side of the cell membrane. Okay, so that means for us, when you prescribe a local anesthetic from outside the body, the local anesthetic need to enter the cells. Okay, then the local anesthetic need to bind to the internal side. Okay, moving to the next slide. Okay, you prescribe the local anesthetic. Local anesthetic, when you prescribe it, LA, LA need to be unionized, or we can call it like uncharged. So LA need to be unionized. You can see it here, need to be unionized. Why is important? Because when the LA unionized, this will be able to cross membrane. Okay, local anesthetic, unionized local anesthetic, able to cross the membrane. That's fine. Here we have local anesthetic again, but local anesthetic here, unionized local anesthetic, uncharged, unable to block the sodium channel here, or the target for local anesthetic. This need to be charged. So what we have here inside, that environment inside the cell, consider like weak base, and this will lead to ionizing the local anesthetic. So the local anesthetic become ionized. So the next slide will be ionized the local anesthetic. So you can see here the local anesthetic will gain proton. Local anesthetic will gain proton and become ionized. So the ionized local anesthetic will be able to bind, the active form will be able to bind to the target side on the sodium channels. And when bind to the sodium channels here, this is the next step. When binding to the sodium channel, the next step will be, okay, binding local anesthetic, ionized local anesthetic to the receptor, lead to the block sodium channel. Blocking sodium channel mean does not allow to sodium to enter the cell and produce like inhibitory effect, inhibit sensation, inhibit pain sensation. So this is a mechanism of action. I will repeat it again. So you can see here, we prescribe local anesthetic uncharged form. Uncharged form very important to be in uncharged form, because when you prescribe uncharged form will be able to cross membrane, and on the inside of cells, local anesthetic will bind to the proton. The local anesthetic becomes charged with the ions, ionized, charged, and the charged form will bind to the local anesthetic receptor. This will lead to the block sodium channel and cause loss of sensation. Okay, this one consider important slide, very important slide, because most of the dentists and maybe local surgery using epinephrine plus local anesthetic. We use epinephrine plus lidocaine, and we have the purpose for that. They said that many local anesthetic have vasodilation property. This cause vasodilation, and this vasodilation will allow the local anesthetic to arrive to the blood. Arriving to the blood will cause systemic circulation. So the local anesthetic arrive to the systemic circulation. This will cause adverse drug reaction, side effect, ADR, adverse drug reaction. Okay, number one. So arriving to the blood circulation, to the blood, and cause systemic effect. Number two, from the name local, we need the medication to be local. When the medication leave the local site to the systemic circulation, that means we have decreased action of local anesthetic. The local anesthetic effectiveness or efficacy will be decreased. What happened also here? So when you have vasodilation, we have risk of bleeding. So we have increased risk of bleeding. So we have three things. Number one, the medication will arrive to the blood, to the systemic, and cause adverse effect, decreased effect of local anesthetic, and increased risk of bleeding due to the vasodilation effect. Now we have the strategy, the policy, the process. We add we add the epinephrine to the local anesthetic. We add epinephrine to local anesthetic. The purpose for that. So what is the purpose of adding epinephrine to the local anesthetic? The purpose, number one, increased duration of action. You can see here what we have here. We have decreased duration of action. When adding the epinephrine, this will increase duration of action of local anesthetic by inducing vasoconstriction. So increased duration of action of local anesthetic, number one. Okay, number two, we believe that we have less bleeding, less risk of bleeding, because we have vasoconstriction also. From the vasoconstriction, the vasoconstriction will lead to the increased duration of action of local anesthetic. Number two, decreased bleeding, local bleeding, decrease risk of bleeding. Number three, this is number one. Number two, number three will be less side effect, because this LA does not arrive to the circulation. So we have three action. Number one, increased duration. Number two, less side effect. Number three, less bleeding. Okay, this is important issue for us. But we have some cautious and warning regarding the combination of epinephrine with local anesthetic. We don't recommend to use epinephrine plus local anesthetic in injected tissues with the end artery supply. We have some tissues like fingers, toes, ears, nose, or venous. These fingers or these organs does not have collateral blood vessels. They have only small, tiny vessels. They don't have collateral blood vessels, small, tiny vessels. When you induce vasoconstriction, the result will be gangrene. So for this reason, we don't recommend to use lidocaine plus local anesthetic when you do the minor surgery on finger, toes, ears, nose, or venous. This is number one. So this is number one for the situation here. We don't use it. So we don't recommend to work on the end artery organs such as finger, toes, nose, and ears, venous. Number two here also, if the patient come to the dental surgery or to the clinic for the minor surgery and this patient has a history of hypertension, we don't recommend to use epinephrine, because epinephrine aggravate blood pressure. So this is another issue we need to take it in consideration as a precaution. Okay, in this slide here, we need to address important concept about the toxic effect of local anesthetic. Local anesthetic, if the local anesthetic, from the name local, this medication should be locally active. We don't intend to bring this medication to the circulation, to the blood, to the brain. If this medication arrived to the brain or central nervous system by mistake or intentionally, this will lead to the something called central nervous system stimulation, and the patient may suffer from restlessness, tremor, and convulsions. This is an important issue here. A patient, for example, if this medication injected directly into the blood, local anesthetic, if the local anesthetic injected directly to the blood, the situation will be severe toxicity, severe systemic toxicity, and this will lead to the death due to the respiratory and cardiovascular depression. So we need to take this in consideration. When local anesthetic arriving to the circulation, this will lead to stimulate of central nervous system, cause agitation, tremors, and convulsion. This medication may lead to the death due to the respiratory and cardiovascular depression. Important maybe issue should be taken on consideration when you use local anesthetic. As we mentioned, we have amide and ester. If the patient suffer from allergy towards one ester, a local anesthetic, this preclude the use of all other ester due to the common allergen metabolite called para-aminobenzoic acid. So if the patient allergic to one ester, we need to maybe not use any esters from the local anesthetic. On the other side, if the patient suffers from allergy to one amide, local anesthetic, that does not preclude the use of other amine. So if the patient suffers from allergy to, for example, one lidocaine, we can move and use another amide from the group without risk of allergy. Okay, this slide here presents some specific local anesthetic agent characteristic. For example, we have cocaine, as you can see from the list, benzocaine, procaine, lidocaine, bupivacaine. So cocaine, this medication could be used for topical anesthetic, local anesthetic, but we don't use it in the practice due to the risk of abuse and addiction. Cocaine, we don't prefer to use it. Moving to the benzocaine applied directly to the skin and the mucus during dental surgery, for example. Benzocaine, and followed by procaine. Procaine considered like short duration of action, 20-minute to 45-minute procaine. Lidocaine, intermediate duration of action, around 1 hour to 2 hours. And as you can see here, most widely used, the lidocaine most widely used, and the duration is 1 hour, 2 hours. Bupivacaine considered like longer duration of action, 400 minutes. So if you need to do surgery for 4 hours, for example, or more, I will go with the bupivacaine because bupivacaine long acting. If you do surgery for the wisdom extract, I will go with the lidocaine, for example, for 60 minutes. It's enough to do the minor surgery. In clinical practice, we have a cream called EMLA, and this cream is a kind of mixture between lidocaine and brolicaine. For local anesthetic, this cream will be applied to the skin, provide dermal anesthesia for the minor surgery when you have wound or something like that. I will share this cream from the Google image to show you the picture for that cream for EMLA with the combination of lidocaine and brolicaine. Okay, you can see the screen here about EMLA cream, lidocaine, and brolicaine. And this one normally used to apply to the skin for to produce local anesthesia. Okay, this slide here maybe present to us the clinical use of local anesthetic. Application of local anesthetic could be applied directly to the skin. We call it service anesthesia. Could be used through the infiltration anesthesia. Could be through the field block anesthesia or nerve block anesthesia, spinal anesthesia, or epidural anesthesia. So we have several type of clinical use of local anesthetic, mainly used in the clinic, in the surgery clinic, on the dental clinic, in specialized clinic, service infiltration, field block, nerve block, spinal, and epidural. So we have here some brief explanation for each step or each type of local anesthesia. Service anesthesia, for example, we use it by applying benzocaine on the skin for the wound. For example, if you have a wound, maybe uh, take care of wound like suturing the wound or something like that. Then we can apply it to the cornea or like mucous membrane. So we can apply this service anesthesia. Moving to the infiltration anesthesia, here with infiltration, the anesthetic will be injected directed into the tissue. We are going to share the picture with you when we finish this slide. Then we have field block anesthesia. Field block anesthesia, here we inject the local anesthetic subcutaneous, and this will lead to the interrupted neural conduction, and this we use it for the extremities, hands, scalp, for example. Then we move to the nerve block anesthesia. We inject it directly on the nerves or on the nerve plexus, for example, brachial plexus, nerves, upper extremity, and so on. Okay, next to what we have again for the some explanation for spinal anesthesia. This one produces anesthesia through the injection of local anesthetic into the lumbar subarachnoid space below the termination of the spinal cord. Then we have epidural anesthesia. We have two type of anesthesia there, and we use it some for some type of surgery, such as like minor surgery or maybe delivery the baby without pain. Okay, this Google image here show you the applying of EMLA with a combination of local anesthetic to the skin, and this produce like service anesthesia as is seen on the image here. Here we have the dental surgery. We were using infiltration anesthesia by injecting the local anesthetic directly in the tissues. This concludes our lecture about local anesthetic as a part of a series related to the central nervous system clinical pharmacology. Thank you for listening and have a great day, everyone.